Introduction. Welcome, medical students, to today's lecture on the fascinating topic of tension headaches. In this comprehensive script, we will delve into the intricate mechanisms underlying central sensitization in tension headaches, explore the role of myofascial trigger points in the pathogenesis of this condition, and discuss the impact of stress, depression, and anxiety on tension headache development. We will also cover the differential diagnosis of tension headaches, various pharmacological and non-pharmacological management strategies, neuroimaging techniques used in research, epidemiology, and demographics. Finally, we will highlight emerging therapies in tension headache management. So, let's embark on this journey into the world of tension headaches and gain a deeper understanding of this commonly encountered neurological disorder. Central sensitization, a key feature of tension headaches, is characterized by increased responsiveness and altered processing of nociceptive inputs within the central nervous system. The pathogenesis of central sensitization involves an interplay between peripheral and central mechanisms. Peripheral sensitization refers to increased sensitivity of primary afferent neurons, while central sensitization involves enhanced excitability of central pain pathways. The activation of trigeminovascular system and subsequent release of inflammatory mediators, such as calcitonin gene-related peptide, CGRP, substance P, and nitric oxide, play a crucial role in initiating and maintaining central sensitization. These molecular and cellular changes contribute to the development and persistence of tension headaches. Myofascial trigger points are hyperirritable spots within taut bands of skeletal muscles. These trigger points often elicit referred pain, which can mimic tension headaches. The taut bands are formed due to muscle overload, trauma, or improper posture. Trigger points in the head, neck, and shoulder muscles have been identified as important contributors to tension headache pathogenesis. When these trigger points are palpated, they elicit characteristic referred pain patterns. The release of sensitizing substances from these trigger points can activate peripheral nociceptors and initiate central sensitization mechanisms, further aggravating tension headaches. Psychological factors, such as stress, depression, and anxiety, have a bidirectional relationship with tension headaches. They can act as triggers, exacerbate existing headaches, or even contribute to the development of chronic tension headache. Chronic stress leads to the dysregulation of the hypothalamic pituitary adrenal (HPA) axis, resulting in increased release of stress hormones, including cortisol. Elevated cortisol levels have been associated with increased pain sensitivity and the development of tension headaches. Additionally, psychological conditions, like depression and anxiety, can heighten pain perception and alter pain modulation, predisposing individuals to tension headaches. Accurate diagnosis of tension headaches ensures appropriate management and patient satisfaction. However, tension headaches share similarities with other primary headache disorders, such as migraines and cluster headaches. Migraines, unlike tension headaches, often present with more severe and pulsating pain, accompanied by symptoms like nausea, photophobia, and phonophobia. Cluster headaches, on the other hand, manifest as excruciating unilateral pain, usually around the eye, associated with autonomic symptoms. A thorough history and physical examination, along with proper diagnostic criteria, aid in the differentiation of tension headaches from other primary headache disorders. The treatment of acute tension headaches primarily involves analgesics and adjunctive therapies. Nonsteroidal anti-inflammatory drugs, NSAIDs, such as ibuprofen and naproxen, are often the first-line agents for mild to moderate pain relief. Combination analgesics, containing NSAIDs and caffeine, may provide enhanced efficacy. For severe pain or refractory cases, triptans, primarily used for migraines, can be considered. These medications act by promoting vasoconstriction, reducing inflammation, and inhibiting nociceptive transmission. Care should be taken regarding the frequency and duration of analgesic use to prevent medication overuse headaches. Chronic tension headaches, defined as occurring on more than 15 days per month for at least 3 months, require preventive management strategies. Tricyclic antidepressants, such as amitriptyline and nortriptyline, have demonstrated efficacy in reducing headache frequency and severity. Selective serotonin reuptake inhibitors, SSRIs, and serotonin norepinephrine reuptake inhibitors, SNRIs, may also be beneficial, particularly in patients with comorbid anxiety or depression. Other preventive agents, such as antiepileptic drugs, for example, topiramate, or botulinum toxin injections, can be considered in refractory cases. Patients with tension headaches often present with comorbidities and associated risk factors. An increased prevalence of psychiatric disorders, including depression, anxiety, and sleep disturbances, has been observed in tension headache patients. Poor sleep quality, sleep deprivation, and abnormal sleep architecture have been implicated in tension headache pathogenesis. Furthermore, certain lifestyle factors like sedentary behavior, irregular meal patterns, and inadequate hydration may contribute to tension headache development. Identifying and addressing these comorbidities and risk factors is crucial for successful headache management. Non-pharmacological approaches can play a significant role in tension headache management. Relaxation techniques, such as progressive muscle relaxation, deep breathing exercises, and guided imagery, aim to reduce muscle tension, alleviate stress, and enhance coping abilities. Biofeedback, a process of providing real-time physiological feedback, helps patients gain control over autonomic responses, such as heart rate and muscle tension. It empowers individuals to recognize and modulate their physiological responses, reducing the frequency and intensity of tension headaches. Cognitive behavioral therapy, CBT, is a psychosocial intervention that targets maladaptive thoughts, emotions, and behaviors. It has shown promising results in tension headache management. CBT aims to identify and modify negative thought patterns, enhance coping skills, and foster behavioral changes. It also helps patients restructure their perceptions of pain and develop effective self-management strategies. CBT can be provided as an individual or group therapy, and its incorporation alongside pharmacological interventions yields better outcomes in chronic tension headache patients. Advancements in neuroimaging techniques have provided valuable insights into the underlying mechanisms of tension headaches. Structural neuroimaging, such as magnetic resonance imaging, MRI, helps rule out underlying structural abnormalities contributing to headache symptoms. Functional imaging techniques, including positron emission tomography, PET, and functional MRI, fMRI, have allowed researchers to visualize and study the altered brain activity in tension headache patients. These imaging modalities aid in unraveling the complex interplay between the pain matrix, emotional processing, and pain modulation pathways in tension headaches. Tension headaches are among the most prevalent primary headache disorders worldwide, affecting individuals of all age groups and genders. The global prevalence of tension headaches varies, with estimates ranging from 30% to 78% in different populations. Females are generally more affected than males. Tension headaches often have a bimodal age distribution, with a peak in adolescence and another in middle age. Understanding the epidemiology and demographics of tension headaches helps healthcare providers develop appropriate management strategies and allocate resources effectively. The management of tension headaches constantly evolves, with ongoing research exploring novel therapies. Non-invasive neuromodulation techniques, such as transcranial magnetic stimulation, TMS, and transcutaneous supraorbital nerve stimulation, TSNS, have shown promising results in reducing headache frequency and severity. Neuromodulation works by altering cortical excitability and modulating pain processing pathways. Additionally, novel pharmacological agents targeting CGRP or its receptors, recently approved for migraine management, hold potential in tension headache treatment. These emerging therapies offer hope for improved outcomes and enhanced quality of life in tension headache patients. In conclusion, tension headaches are a complex neurological disorder involving central sensitization and myofascial trigger points. Psychological factors like stress, depression, and anxiety contribute to tension headache development. Differential diagnosis ensures accurate management, while pharmacological and non-pharmacological approaches aid in acute and chronic tension headache management. Comorbidities, associated risk factors, relaxation techniques, and cognitive behavioral therapy play vital roles in patient care. Neuroimaging techniques provide valuable insights, while understanding epidemiology helps tailor interventions. Finally, emerging therapies provide promising avenues for future treatment strategies. By acquiring a comprehensive understanding of tension headaches, medical professionals can better diagnose, manage, and ultimately improve the lives of individuals suffering from this debilitating condition.